She did, sir.
She did.
You were there?
Yes, sir.
We are live.
A very good evening, everyone. Welcome to iFocus Online Lecture 306, number 13 in Ocular Oncology module. So today we have with us Dr. Mohd Shahid from Sankara Nethralaya, Kolkotta, and Dr. Kirthi Koka from Sankara Nethralaya, Chennai, with a very interesting session of OSCE in Ocular Oncology. We also have few hot seat participants to make the session very interesting. So just a brief introduction of our OSCE takers today. Dr. Shahid did his MS from Aligarh Muslim University and long-term fellowship in orbit and oculoplasty from Sankara Nethralaya, Chennai. He worked as a consultant at Sankara Nethralaya, Chennai for 3 years, and currently he heads the Department of Orbit and Oculoplasty at Sankara Nethralaya, Chennai and Kolkata. He's head of the academics at Aditya Birla Institute of Sankara Nethralaya in Calcutta, and he has more than 120 publications in peer-reviewed journals to his credit, authored several book chapters, and his area of interest is orbit and adnexal oncology. Welcome, sir. Dr. Kirthi Koka did her MBBS from Kilpauk Medical College, Chennai, and went on to do her MS from Stanley Medical College, Chennai in 2013, and a long-term fellowship in orbit and oculoplasty, Sankara Nethralaya, Chennai. In 2016, she received the award of Best Outgoing Fellow. She also did her short-term observership with Beta Ismaili at MD Anderson Cancer Center in Houston, Texas. Currently, she is an associate consultant in Department of Orbit, Oculoplasty, and Reconstructive and Aesthetic Services at Sankara Nethralaya, Chennai. She has numerous publications in national and international journals, and her area of interests include orbit and adnexal oncology and thyroid eye disease. A very warm welcome to both of you, and over to you.
Thank you so much, Shafali.
Yeah, thanks a lot, Shafali, for that nice introduction. And at the outset, I'd like to thank Dr. Honavar and the whole of iFocus team for giving us this opportunity to carry out this OSCE session. So, are the slides visible now?
Yes, yes.
Yeah. We'll just be starting with the OSCE. This is the first question. So, describe this clinical photograph. Is anybody there to take this question?
Dr. Vaibhavi is unmuted.
Yeah.
Sir, it is upper lid calagion.
Okay.
Sir, definition. Sir, it is a chronic hypogranulomatous inflammation of meibomian gland.
Yeah.
Sir. Yes, sir.
Yeah. Next, what management options?
Sir, management options can be both medical as well as surgical. Medical, we give dry hot fermentation, and we can also give intralesional steroids. And in surgical, we can do incision and curettage.
Yeah.
Sir, oncology implications, sir, recurrent calagion in adult patient usually mimics sebaceous gland carcinoma. So should be sent for histopath examination. And sir, literal meaning of this condition is lump.
Okay, great. Yeah. So you answered all of them. So, and where would you like to give the incision? When you will do an incision and curettage, what will be the your orientation of the incision? Horizontal, vertical?
Sir, horizontal, vertical, sir, so that we do not cut the meibomian glands.
Yeah, correct. So this is the calagion, and the oncology implication is that many times sebaceous gland carcinoma, it can masquerade like a calagion. And the important findings which will differentiate a sebaceous gland carcinoma from a calagion is that sebaceous gland carcinoma can go beyond the tarsal plate. There will be associated loss of eyelashes, distortion of eyelid contour, and complete effacement of meibomian gland porifices. The overlying skin can be adhered to the underlying mass, or there can be an overlying ulceration also if it cuts through the skin. So this was the question 1. Now this is the second question. You can see another mass from the eyelid margin with overlying crusting. Anybody can? What is this? What are the causes? Anyone? Vaibhavi?
I think Varshini is trying now.
Varshini, yeah.
It is pyogenic granulomas. It is.
Correct.
It is might be
So what are the
granuloma,
causes? Yeah.
might be trauma,
Okay.
infection.
Okay. Yeah. Yeah. Trauma, infections, mostly hordeolum, external and internal hordeolum.
Yes, sir.
Can in the healing case can cause a pyogenic granuloma. So what is the scientific correct term and treatment? So it's actually a lobular capillary hemangioma, and it's the most common acquired capillary vascular tumor. And what is the treatment? Treatment is surgical excision. Any recent advances in the management of pyogenic granuloma you are aware of?
Intralesional steroid.
Intralesional steroid and topical chemolol.
Okay.
And pyogenic granuloma was first identified and labeled as Botryomycosis hominis. It was thought to be a fungal infection. So this is the question 3. Sir, with mass in a pediatric patient, what does it look like? Anyone? Rohi, Varshini?
Would you want to try?
Yeah, it looks like a hamartoma.
Yeah, it's a hamartoma, but what is it?
Yes.
You can see an upper lid swelling.
Yeah, it's a mass,
It's a mass lesion seen in a
a vascular
pediatric.
mass, as
Vas-
you can see.
yeah.
Yeah. So it's a capillary hemangioma. The capillary hemangioma is a hamartoma. What is a hamartoma? It's a normal, abnormal proliferation of cells which are normally present in that area. And choristoma, proliferation of cells which are normally not present, like a
Not
lymphocyte.
present in that area.
So systemic associations of capillary hemangioma.
It can be associated with Sturge-Weber syndrome.
No.
Any neurofibromatosis syndrome.
It can be associated with Faces syndrome and Kasabek-Meri syndrome.
Yes.
Faces and Kasabek-Meri. Kasabek-Meri is consumptive coagulopathy. What are the treatment options? Treatment of choice nowadays for capillary hemangioma? The treatment of choice is propanol and the mechanism of VEGF inhibition. So how was propanol discovered, the treatment option? How did people come to know that propanol can be used as a treatment for capillary hemangioma? Anybody from the participants? Varshini? So it was seen that in few patients where propanol was being tried for other cardiac conditions, patients' hemangiomas, they incidentally regressed where propanol was used. So from then it was published as a letter to editor in New England Journal of Medicine as a case of cases of 5 patients, and then gradually it took over, and now it's the treatment of choice. Okay, so describe this lower lid lesion. Anyone?
Who do we have now other than
Ruju, would you want to try?
Ruju?
Yeah, Ruju, you want to try? Yeah, it's a basal cell carcinoma. Okay. Are you aware of any systemic association of basal cell carcinoma?
Bazek syndrome.
Bazek syndrome, correct. More common than Bazek's?
Xeroderma pigmentosa.
Yeah.
Xenoderma pigmentosa.
Xeroderma pigmentosum. Then Golin-Gott syndrome. And you see multiple basal cell carcinoma.
What is Golin-Gott's otherwise called? Golin-Gott's is otherwise called?
Basal cell nevus.
Yeah, correct.
Basaloid nevus.
Yeah. So what do we do for this lesion? What is the treatment of choice for this the lesion which is seen? What is the management for this option? Management option.
Wide local excision with margin clearance.
Correct. Wide local excision with margin clearance. And what are the recent advances in the management of basal cell carcinoma?
Hedgehog cell inhibitors.
Yeah, Hedgehog cell pathway inhibitor, and that drug is known as Besmodegib.
Desmodegib.
Besmodegib, and especially used in cases of this syndromic basal cell carcinoma, where you see multiple basal cell carcinoma, like Golden-Gott syndrome, xeroderma pigmentosa, patient with familial basal cell carcinoma. And the trivia question is, what are basal cells? Anyone? So basal cell carcinoma, they arise from basal cells. So these are epidermal cells with the progenitor cells. They give rise to new epidermal cells from the located in the base of epidermis, and they produce new cells. So these are basal cells. Okay, identify this common eyelid tumor.
Tuba, would you want to take it?
Yeah, sure. It's a nodular lesion which is arising from the tarsal plate, likely to arise from the meibomian glands of the eyelid in this scenario. So this looks like a sebaceous gland carcinoma.
Okay, so what are the other ocular structures from where it can arise?
The glands of Zeiss.
The
glands of Mohd,
Zeiss
and from the caruncle.
Caruncle, and where else can you see meibomian gland? Eyebrows also.
Eyebrows.
Right from there are some sebaceous gland in the region of eyebrow also. Any systemic association you are aware of in case of sebaceous gland carcinoma?
Yes, sir. Muir-Torre syndrome.
Yeah. So what happens?
Pardon, sir?
What happens in Muir-Torre syndrome?
This sebaceous gland carcinoma is associated with the GI malignancies.
Okay. What is MAB biopsy?
MAB biopsy is where multiple specimens are taken from the palpebral surface, from the fornical and the bulbar conjunctiva. It was initially
the whole of the ocular surface.
From the ocular surface.
Whole of the ocular surface, multiple specimens, 17 to be precise.
To be precise. Initially described by Putterman and then later.
Yeah. Exactly. And what is the management for this lesion here?
First would be to do a clinically clear margin wide excision with the intraoperative frozen section to confirm our diagnosis.
To confirm the diagnosis, you will do an incisional biopsy, and then what you are telling is intraoperative frozen section margin control is the treatment. So with the incision biopsy, you confirm the diagnosis that it's a sebaceous gland carcinoma. Then under frozen section margin clearance, the margin of 4 millimeter, you do a wide local excision with eyelid reconstruction. Okay.
Now can anyone tell the stain which can be used on histopathology to confirm?
Yeah.
Alredo.
Yeah. Right.
And recently we used adipophilin stain. And what does the word pagetoid mean?
Pagetoid means spread of the tumor into the overlying epidermis or the conjunctival surface, like the epithelial surface. It's a widespread spread of the tumor.
Spreading.
Intraepithelial spread of the tumor is referred to as the pagetoid.
So that's why it's called pagetoid, because it mimics the Paget disease of the breast. So that's why pagetoid, not exactly the Paget. So pagetoid. Okay, very simple. What is this?
Neurofibroma.
Rolika, you're taking this, yeah. Neurofibroma.
So the neurofibroma associated with either neurofibroma like NF1 or von Rockler-Ecklinghausen syndrome. And what will you look for in the CT over the skin and iris? In the iris, you can see heterochromia. Because it can be present, lymph nodule, sorry. And over the skin, we can see ash leaf spots and cafe au lait spots and ash leaf spots, and and freckles and axillary freckles also. And in the CT scan, we will look for sphenoid dysplasia. In these patients, there is sphenoid dysplasia, which causes a pulsatile proptosis. And
two tumors, you told 2 tumors?
Sorry, sir?
Name 2 associated tumor with this condition.
The 2 tumors, the optic nerve glioma will be present. And what else?
Acoustic schwannoma.
Acoustic, right.
NF1 glioma, NF2 schwannoma.
Schwannoma, right.
What is phacomatous?
Phacomatous is any of the like dermatological manifestations, the diseases with dermatological manifestations.
Yeah, neurocutaneous.
Neurocutaneous.
Neurocutaneous the phakomatosis. So are you aware of some other common phakomatosis apart from NF?
Tuberous sclerosis. That would be
Tuberculosis is a phakomatosis, right?
right. And
More common than tuberous sclerosis. Sturge-Weber syndrome,
Sturge-Weber syndrome,
von Hippel-Lindau syndrome,
VHL.
and even the faces syndrome, which is seen in association with capillary hemangioma, is a phakomatosis. Faces in. So that was more or less all about NF. Yeah, so this is a simple one. This characteristic ASVCT picture. Subha, can you describe it?
Yes, sir.
Yeah.
It shows this is an anterior segment OCT image, which shows an elevated lesion with a hyperreflective epithelium, a homogeneous stroma with minimal back shadowing, and the relative thickening of the limbus and loss of transition zone between the two layers, basically the cornea and the.
It is an abrupt transition between
the two.
There is an abrupt transition, between normal and abnormal. So this characteristic ASOCT is seen in
ocular surface squamous neoplasia.
OSS. Roju, would you like to take it? What is this? Can you describe this lesion in conjunctiva?
It is a ill-defined salmon pink colored lesion.
So it's a salmon patch, right?
Yes. So likely diagnosis would be conjunctival lymphoma.
Or a conjunctival lymphoma associated with orbital lymphoma. So what is this characteristic radiological feature here?
So basically molding around molding of the surrounding.
Yeah, ill-defined heterogeneous mass which is molding around the globe. So what types of lymphoma would you see in orbit? The common types?
Non-Hodgkin's B-cell lymphoma, sir.
Of course, it's NHL. So what are the types of NHL?
Extranodal marginal zone lymphoma is the most common. Second would be follicular lymphoma. Diffuse large B-cell lymphoma. Third one.
Myeloma. So these are the common ones that you see. And what is the management of choice?
CRT.
Yeah, if it is localized to the orbit, then radiotherapy. If it is a systemic spread, then both chemo. Okay, so Antony A and B areas. So here are 6 slides.
What
one is Antony and B. Any idea?
Varshini, would you want to take it?
Varshini?
Keratin pulse is seen in squamous cell carcinoma, sir.
Correct. Antony and B are seen in. So this is keratin pulse. This is keratin pulse, which is seen typically in a squamous cell carcinoma.
Yes,
this
sir.
is Antony and B. Okay, you go ahead and tell the other ones which you are aware of. Varshini.
Palisading is like in sebaceous gland carcinoma, sir.
No, basal cell carcinoma.
Okay.
Nuclear palisading and crush artifacts. Crush artifacts are typical of basal cell carcinoma. Okay. Imperipolysis. What is imperipolysis? You know what is imperipolysis?
No, sir.
So, an intact cell within the cytoplasm of another cell.
Okay, sir.
So here, you see this halo?
Yes, sir.
And the cell inside. So a lymphocyte within a histiocyte. That's what it's showing this picture. And it's typically seen in orbit or at next site seen in roside of disease. This imperipolysis.
Okay, sir.
And oil red O and AW5. This is oil red O stain. So both these are used in sebaceous gland carcinoma. Shadow cells are cells, specifically philic cells, that over a period of time they lose their nucleus and appear like ghost cells, like here in these pictures, and they are seen in pilomatrixoma. This shadow cell.
I think in neurolemoma, no, sir?
Yeah, schwannomas, peripheral nerve tumors. Antennae A are packed areas, hypercellular areas, and B are hypocellular areas. So this is A and B. So this antennae and B pattern is seen in peripheral nerve sheath tumors, mostly schwannomas. Okay. Anyone?
Ruhi, would you want to take it?
Yeah. So, so it appears to be a retinoblastoma.
Okay,
I want
so
differential diagnosis.
what can you give one DD on fundus? Any other thing which can look like this? So if you look at coloboma, retinocoloboma, it will look like this.
Yeah, but there are feeder vessels on the surface.
Yeah.
Yeah.
Okay. What are the causes of leukocoria?
Causes of leukocoria could be congenital cataract, persistent hyperplastic primary vitreous. It could be Norris disease.
Yeah. So I have a mnemonic for leukocoria. It's I remember it like TT crab, Toxopora, Toxoplasma, Coats disease, cataract, ROP retinoblastoma, associated hematoma, and persistent fetal vasculature, TT crab. So these are the causes of leukocoria. Two important investigations that you do to confirm the diagnosis in retinoblastoma.
B scan.
Mm-hmm.
Indirect ophthalmoscopy is done. B scan is definitely confirmatory.
So endophthalmoscopy is not investigation.
Okay.
So you'll do an MRI.
MRI brain, MRI orbit.
Okay, so the classic mutation responsible for RB.
There's not some two-hit diagnosis hypothesis which is used.
And where is that mutation located?
Chromosome 13. 13.
No. Or Shafali will help you.
The Knudsen's two-hit hypothesis. So we have
mutation is located on RB mutation.
RB mutation, RB gene mutation.
No, it is on which chromosome?
13q14.
13q14.
13q14. 13q14.
Yeah, so who answered 13q14?
Yeah, everybody landed up answering together in one shot.
But Shubha was the first.
Yeah.
Okay, sure. Okay, we'll come to that later on. An interesting thing about 13q14. But first, we'll finish this slide. What is the classification system that is used? The classification system.
Currently, we are using the International Retinoblastoma Classification System.
Yeah, grouping from 8. Okay, so Shubho, so you told 13q14. So if you can answer what does Q stand for, so you win a chocolate from me.
Q refers to the long arm of chromosome 13.
So is there any P also or any R also?
There is a P which refers to the short arm of chromosome is referred to as P. That's a normal nomenclature for a chromosome.
Yeah, so what does P stand for?
P stands for a short arm of chromosome.
But why? What does P mean?
I'm
So P stands for petite. P stands for petite. So that is the short arm, and Q doesn't stand for anything just because it's a long arm and P was named as short arm. So Q came after that. So 13q14. And it's not actually 14, it's 13q14. 1 is band and 4 is sub band. So it's actually 13q14. Okay. So we can cover this one. Describe the fundus picture. Should I describe this? Another diagnosis.
Nisa?
Yeah. Or anybody else?
It's a melanotic choroidal lesion.
Most likely diagnosis, Shafali?
Most like the first diagnosis in my mind would be choroidal melanoma.
Okay, so what are the important investigations would you do?
So B scan is shown. It shows a collar stud appearance with overlying retinal detachment.
Okay.
Otherwise, clinically, we have to see, like the B scan will tell us about the thickness. Clinically, we have to see the fluid. which we can also see on OCT. You have to see the orange pigment on the lesion, like choroidal lesion surface, the symptoms, and
treatment options for melanoma in
it
general.
depends on the size. We have a small size melanoma, intermediate size, or large size melanoma. Small size, we can even treat with the transpapillary thermotherapy. For medium size, plaque brachytherapy can work. And for large size melanoma, enucleation is an option.
Yeah, correct. So that was more or less about choroidal melanoma. So I think from here on, Dr. Kirthi will take up.
Okay, so here we have a 8-year-old girl coming with the sudden onset of proptosis, and we get an investigation done, and this is the picture that you see on imaging. So who's the taker for this?
Kirthi, should I put the slide for you?
Yeah, you can move the slides.
Okay.
Yes. What's the diagnosis?
Yes, so basically acute onset with the subconjunctival hemorrhage in a young girl would be likely would be lymphangioma.
Correct. Lymphangioma. So acute onset generally with the thing is lymphangioma. So usually it occurs following
episode of URTI.
URTI, sometimes even after trauma. Okay.
Yes.
And can you describe the classic MRI findings which help to clinch the diagnosis?
Yes, basically it's a multi-lobulated lesion with fluid levels, and sometimes calcification is also seen.
Right. What does the calcification mean if it is there? What is it called? Phlebolytics. Sometimes they're going to be not purely lymphatic malformations, there can be veno-lymphatic. Also, can you tell me which age group they generally occur in?
Usually 6 to 10 years.
Yeah, usually the first decade of life. Okay.
Yes.
And they're usually asymptomatic until the first attack of URI. So what's the treatment of choice, current treatment of choice?
Basically cyst aspiration with injection bleomycin.
So what is bleomycin? What agent is it? How does it help basically?
Bleomycin is basically a sclerosing agent.
Sclerosing agent. So any other sclerosing agent that you know that can also be used?
Picibanil.
Picibanil, yes. You can use picibanil also. Some people also use sodium tetratisal sulfate, though it's more stronger than inflammatory agent. Before picibanil, bleomycin, what was used?
Ethanolamine.
Steroids
also were used. Yes, intralesional steroids were also used. Okay. Yeah. Can somebody shift the slide? Next slide. So you've answered most of it: lymphangioma, URI, fluid levels. Also, they have micro and macro cysts. Okay. So this is a male patient who presents an OPD with proptosis, and you can see he's got an infranasal dystropia. After an imaging and doing a biopsy, this is the characteristic histopathology picture that you see. So can you describe the histopathology, and based on that, what is the diagnosis? Ruhi? Can we have Ruhi take the answer?
Yeah, 1 second. So it appears to be a lacrimal gland tumor, pleomorphic adenoma.
Pleomorphic adenoma. Why do you say pleomorphic adenoma? What is this characteristic histopathology picture that you're seeing?
I see vacuolated lesions here, vacuolated spaces.
So this is basically what you say is characteristic Swiss cheese pattern. Okay, sieve-like appearance, Swiss cheese appearance. Okay, so now what is the diagnosis?
Ruhi, are you there?
Yeah, I'm there. Can you hear me?
So now that I've told you Swiss cheese, what is your diagnosis?
Varshini, would you want to try?
African Swiss cheese.
Okay, so it's adenoid cystic carcinoma.
Adenoid cystic
carcinoma. Okay, they have a characteristic Swiss cheese or a sieve-like pattern. So what is the mode of spread of these tumors?
Lymphatic spread.
Before lymphatic?
Perineural spread.
Yes, perineural is the most common, followed by local and hematogenous spread. Okay. And so what is the most common benign tumor which arises from this gland?
And that would be pleomorphic adenoma.
That would be pleomorphic. The next slide. That's the answer. So the Swiss cheese, the characteristic histopathology you should know here is it has a combination of epithelial and myoepithelial cells. Okay. And they form these vacuolated spaces, which gives a characteristic like a Swiss sieve-like pattern. Okay. So here's another patient who's having proptosis of the right eye. And you see the imaging, you see a well-defined lesion here. Okay. With homogeneously taking up, it's homogeneous enhancing. So what is this tumor now? Varshini? Based on the location of the gland, location of the lesion, what would be the most, and the characteristic appearance on imaging, what will be your diagnosis? Anyone else?
Ma'am, it's a pleomorphic adenoma of the
Right, pleomorphic. What is it also called as?
benign mixed cell neoplasm.
Benign mixed cell. So what are the histopathology features of this tumor?
It has a presence of a capsule or a pseudocapsule with
Yes, pseudocapsule.
epithelial and myoepithelial cells.
With both, yeah, epithelial and myoepithelial. Okay. So pleomorphic sometimes can go on to form a malignancy, especially recurrent ones. So what is the common malignancy which occurs?
Adenoid cystic carcinoma of the lacrimal gland can arise from pleomorphic adenoma.
Yeah, but most commonly, it can be adenoid cystic, but generally it is a
Pleomorphic adenocarcinoma.
Adenocarcinoma.
adenocarcinoma. Yes, it's also called carcinoma ex pleomorphic adenoma. So what are other inflammatory conditions that can arise from this gland? Commonly, what do you see?
It can involve either the orbital lobe or the palpebral lobe.
Yeah.
The dacryodenitis, or if it depends if it is unilateral or bilateral. It can be post-viral dacryodenitis, or if it is bilateral, you have to think in terms of sarcoidosis, IgG4 related disease, etc.
Correct. Vaginal, sarcoid, jaw growth, these are all things that you are generally associated. Okay, good. The next one. So here again, we have another patient, again with prominence. Again, you see a well-defined lesion intraconal, and on histopathology, this is the characteristic picture. So what is the diagnosis? Who do we have here now? Cavernous hemangioma, correct. It's cavernous hemangioma. Generally occurs in which age group?
Middle age group is the most common one.
Yeah, middle age. And male or females?
Yes, it's more common.
It's a female predominance. And can you describe this histopathology picture?
Blood-filled, basically it's like blood spaces and
separated by? So fibrous septa. Okay, so you have vascular chest spaces lined with endothelium separated by fibrous septa. Can you tell me 5 approaches to the orbit? Surgical approaches to the orbit? Any 5 types?
Approaches, depending on the location of the tumor, we can have like an basically approaches as in like those kind of approaches.
Yeah, just any. Yeah, usually they ask right in for DMBs, they generally ask what are the named approaches to the orbit that we know of.
So we can have like an anterior orbitotomy, lateral orbitotomy, or inferior orbitotomy. The approach can be transconjunctival. Location-wise, it can be like lid crease approach or subbrow. And
Yeah,
if we
correct.
Yeah.
So you can have various approaches. So you should know at least few of them for exam purpose. So stellar right, your modified Lynch incisions, vertical lid split. Okay, then you have your swinging eyelid incision, etc. Okay, so yeah. Next slide. This is a young child presenting with a bilateral proptosis. Okay, and she looks very toxic. She's got high-grade fever. Imaging, you see ill-defined homogeneous lesion along the superior orbits. And this is the clinching diagnosis test. Okay, so can somebody tell me what is this test which was used to confirm the diagnosis?
Peripheral blood smear, ma'am.
Correct, peripheral blood smear. What do you see on the peripheral blood smear?
Immature cells.
Correct. Immature blast cells. So what's your diagnosis?
Leukemia.
Correct. Leukemia. So leukemia, if it's only confined to the orbit as a manifestation, then what is it called?
Granulocytic sarcoma.
Yes, granulocytic sarcoma or chloroma. Okay. What are the other common tumors which metastasize to the orbit in the pediatric age group? The most common is leukemia. What are the other ones?
Wilms tumor.
Tumor,
Wilms.
Blastoma.
metastatic
Neuroblastoma.
blastoma.
Yeah. So these are the common ones which metastasize to orbit. So it's important to keep in mind. Okay. So rather than running into an incision biopsy, you can do either a peripheral smear, you can do an ultrasound abdomen. It'll pick up your neuroblastomas. So other investigations that need to be done once you have diagnosed it as a leukemia, what is the next step? What will you do next? Sorry, I didn't get that. You'll do a bone marrow biopsy, a bone marrow aspiration will be done. Okay. And how is leukemia treated?
Systemic chemotherapy.
Systemic chemotherapy is the
We
treatment of
don't need to
choice.
do anything for the orbit. We'll refer
Yes.
the hematologist.
Refer to oncologist. Correct. Yes. Okay. So immediate peripheral smear, clinch the diagnosis and referring with the treatment. Okay. Okay. Next one.
Okay, Raju, can you tell what is the most common primary orbital malignancy in a child?
Sir, rhabdomyosarcoma.
Yeah. And what are these group of tumors called? This leukemia, neuroblastoma,
Round blue cell.
Round cells tumors.
Round cell.
Round cell tumors. They call round cell tumors.
Tumors are called.
Any other round cell tumor that you all know, which is again common?
Spinnet.
Primitive neuroectodermal tumor.
Primitive neuroectodermal. Any other, which is intraocular, which is also round cell?
Retinoblast.
Yes, retinoblastoma. So most of the tumors which are in the pediatric age group are all round cell. Ewing sarcoma also is a round cell tumor. Ewing sarcoma. Okay.
Is a round cell tumor. And what is that classical sign which is seen in neuroblastoma? What is this classical sign called?
Raccoon sign.
Raccoon sign. You have bilateral ecchymosis, which is also called raccoon sign.
And what if the leukemia is only confined to the orbit?
That they said granulocytic sarcoma.
Aleukemic leukemia it's called. Aleukemic leukemia. The leukemia is not inside the blood but inside the orbit.
The next one. So this is a child with gradually progressive prominence, and imaging is showing this lesion in the orbit. Can somebody confirm or tell me what the diagnosis and describe the MRI?
Debavi, would you want to try?
Ma'am, there is fusiform enlargement of the optic nerve, suggestive of optic glioma.
Optic nerve glioma, yes.
Ma'am, the
So
same.
here, what is it also called? Other name?
Ma'am, pilocytic astrocytoma.
Pilocytic astrocytoma, correct. Okay, and generally occurs in which age group?
Ma'am, first decade of life.
First decade, okay. So what is the normal, what is the syndromic association of glioma that you should, we already discussed it, neurofibromatosis. Yes. So what is the advantage if a child has glioma and neurofibromatosis? What is the, generally how does it?
What is the clinical implication if the child is having both neurofibroma and optic glioma?
No, glioma.
Yeah, what is the implication? Or how, what will the effect on the progress of the tumor? Is it a favorable condition or will it further worsen the tumor?
Generally, it can be bilateral, I mean, such conditions.
Yeah,
it can be
they're generally bilateral
but
and they have a good prognosis. Vision is generally maintained in such children. Okay, the ones which are sporadic are generally more aggressive and associated with drop in vision. But the ones with neurofibromatosis generally have better vision. Okay, and the sporadic ones tend to progress beyond the optic nerve. They even tend to involve the chiasm and optic tract, optic radiations also. Okay, and then really the prognosis is pretty poor. So we already discussed the clinical signs. Dr. Shahid already discussed, right? Cafe au lait spots, few clinical signs, cafe au freckles, Lish nodules, and then you can also have neurofibromas. Neurofibroma nodules you can have. So can you tell me any other tumor that you know that arises from the optic nerve, common tumor that we know of?
Nerve sheath meningioma.
Yes, optic nerve sheath. In which age group does that occur?
That's like in 60s, 50s and 60s.
Yeah, generally in the 4th to 6th decade of life, more common again in also females. Okay.
Shefali,
So-
you answered no, optic nerve meningioma.
No. I think Vaibhavi answered, no?
Who answered?
Vaibhavi, sir.
Vaibhavi, I think.
Yeah, what is the characteristic imaging finding in optic nerve sheath meningioma?
One characteristic imaging and one characteristic histopath finding in meningioma.
Tram track appearance.
Correct, tram track appearance.
Correct. Tram track appearance.
Histopathology.
Histopath. Anyone? Ruju, can you tell histopath characteristic on histopath in meningioma? Shefali?
Not sure of etiology.
Ever heard of Samoma bodies?
Samoma bodies you will have.
Some of my bodies.
Can somebody tell me the classic triad which is seen in optic nerve sheath meningiomas? Triad of Shubha? Anyone else? Any takers for that? The triad?
Octociliary shunt.
Correct, octociliary shunts.
Visual loss,
Vision loss, and then
optic atrophy.
tumor of, yes, optic atrophy. Okay.
Who
So
told this? Rohit.
Yeah.
So Rohit, can you tell what is this triad called?
What is?
What is this triad called? Is there a name for this triad? Eponym.
No, sir, I don't remember the name.
It's called Hoyt's triad. Hoyt.
Okay, Hoyt's triad. Yes.
and one more thing is it's not always seen. It can also be the similar triad can be seen even in other lesions of the optic nerve, but it has been described characteristically for meningiomas. Okay. What is the treatment for glioma?
They respond very well to chemotherapy.
Chemo.
Yeah.
So all children will be treated with chemo.
Observation.
Yeah, observation in case it's not affecting vision. Chemotherapy is not the preferred treatment and in older children. Radiation also can be given. Okay.
Stereotactic.
Yeah. Stereotactic radiotherapy can be given.
Okay, Ruju, can you tell one interesting fact about this tumor? Because of which we would like to observe it also.
About which tumor, sir?
This
This
tumor.
gliomas.
optic nerve glioma. A very interesting thing. What can happen if you keep observing the child? The tumor is not growing individually if it is constant. And then suddenly one will see that the tumor has regressed. This is one of the tumors which can spontaneously regress.
Yeah,
Optic nerve.
spontaneous regression. So two things with
And-
spontaneous. One is gliomas, the other benign tumors, capillary hemangiomas. So capillary hemangiomas also you don't need to treat them. They have two growth phases, right? They have a proliferative and then they have the involution phase. So they can also spontaneously regress. You only treat if they're having amblyopia, cosmetically disfiguring. Okay. Same with gliomas, you treat only if they're going to be affecting the vision. Okay. What is that one? It's a child. What test can you do for glioma to know whether the optic nerve function is dropping or not? Because a child who's 1 year old is not going to respond to vision, right? What can you do?
PEPs?
Yeah, you can do VEP. Okay. VEP can be done. Serial VEPs to monitor the vision. Okay. Monitor optic nerve function. Sorry. Okay. Next slide.
Yeah.
That's the last
Right.
one that we have for today. Oh, we're done.
So it is-
Okay. I thought we had one more slide. Yeah.
Yeah.
Okay. Yes.
Okay.
Yeah. So if there's anything else people would like to discuss on ocular oncology, it'd be like we'll try. We can answer.
So very, very
Ma'am,
interesting slides and yeah, questions. I think our postgraduates would have like really benefited from it. So other common conditions that can come, sir, as slides, especially histopathology, because obviously we don't end up reading that much. So any tips
Mhm.
for postgraduates how to kind of like revise the histopathology or kind of like know more about it?
Yeah, based for postgraduates, I think you should be well versed with like retinoblastoma, because retinoblastoma can be kept in exam, especially those rosettes. So that you should be aware of. Actually, the common conditions. So retinoblastoma is one of them. Then cavernous hemangioma is also very simple slide, where you will see large vascular spaces filled with blood. So that also can be kept in your exams.
BCC, I think they keep.
Yeah.
On the
Skin
skin
basis.
eyelid lesions,
Yeah.
they tend to keep
Basis-
BCC because of the palisading
Yes.
appearance. No, they tend to keep BCC. Sometimes they keep even squamous cell because the keratin pearl is something you can easily pick up.
I don't know like what is the pattern nowadays. But yeah, during our MS we had this one table for histopathology, and invariably you will use to have this retinoblastoma slides. Retinoblastoma.
I think both of you have really very well taught them about how to take each and every question, how to really think about all the entire spectrum displayed. I think that was the quality and the important part of the OSCE questions. They went in a sequence and they were like, kind of ensuring that all the questions are covered, so that if whatever questions they get in their exams, they have all been covered. Is that right, Shifali? Would you agree?
I totally agree. I think like from the diagnosis to like the treatment part and also the trivia that sir put in all the slides, that was very interesting.
Yeah,
Some-
the trivia is for all of you to enjoy it.
Enjoy actually. Yeah. I enjoy trivia a lot. I enjoy trivia a lot. So yeah.
And also there
Yeah.
might be some examiners who would actually give you extra pointers if you answer the trivias.
Yeah, if I'm especially if I'm one of the examiners, yeah, I'll definitely complete the question.
That
Another
is
pointer I would like to tell all the postgraduates is even if you don't know the diagnosis in radiology or anything that you're describing, just describe it clinically so
Yeah.
that you ultimately reach to the end and the examiner will actually
Yeah,
give
they will actually give you some hints. If you actually describe
Yeah.
it, they will give you hints and help you actually come to the diagnosis.
correct.
It's
So
very
rather-
important to watch for the hints that the examiners draw. Right?
Correct. Because
So,
rather than
and yeah.
thinking, because we all fumble, because we suddenly want to think about the diagnosis, which obviously
Correct,
will
yeah.
not come if it's especially in an oncology case or like a plastic case. Even for a postgraduate, we don't read that much of plastic and oncology as a postgraduate student. So I think
Yeah.
just go stepwise, just describe the MRI, what cut it is, and T1, T2, describe the lesion, heterogeneous, homogeneous, which part it's arising from. I think that will fetch you the marks that you're looking for.
Right.
Correct. Yeah.
And another thing with examiners is like for simple things like even like doses and they always know all the classifications, acute, chronic classifications. That's something that's very important. Know the most important causes for in children, in adults, for tumors, benign malignant tumors. It's very important to know acute onset, infective etiologies, what are the bacterial, what are the fungal. These are things you should know classifications. So that will really help.
Right. Actually, as postgraduates, they, as ma'am and sir have shown, they have taught you all the management aspect too. But as postgraduates, they might not expect you to give the entire management part, but they will definitely
Correct.
expect the classifications and the categorizations.
Yeah,
Because
that's what they'll want you to know. If you don't know that treatment also, they will exempt. They'll be like, it's okay if you don't know, but they want you to know the definition and the classification. Those are two things you need to know for any diagnosis.
right. And it's best to, and if at all you're confused and you know that you're about to make a blunder, it's best to remain silent or skip the
Yeah.
question than go for an answer which puts the examiner in a tough spot. That till
Yeah.
now everything was going right. Now what do I do?
Exactly. Yeah.
Right. One more question, sir. That in the case that you had shown about the basal cell carcinoma, in the first patient, right? So how would you usually go ahead with the systemic assessment in the patients with basal cell carcinoma? Would you do anything?
No, see, the head and neck oncologists. So, like we had a discussion with them. So, generally, in cases of basal cell carcinoma or sebaceous carcinoma, which are more or less localized to a segment of the eyelid and not very much advanced. There is no associated lymphadenopathy. So, systemic workup is not needed. At least in basal cell carcinoma, it's not required. If it's like the tumor which I had shown, small tumor. So, and if at all, if you're planning, so you can do chest X-ray, ultrasound abdomen to get a gross idea that everything and a USG neck, ultrasound neck. So rather than going ahead with the PET CT, which I think you should do in a case of sebaceous gland carcinoma with vegetoid spread or advanced squamous cell carcinoma.
Right. Right, sir. Another question is that Nethralaya happens to be one of the few centers in India which are treating with plaque brachytherapy, and I think at Nethralaya it's iodine plaque that is being used. So, what is the cutoff for height that is kept at your center for intraocular tumors like melanoma here?
Yeah, so since like we don't treat intraocular tumors, so here in Sankara Nethralaya, the intraocular tumors are purely treated by the
retina specialist.
So we treat orbit and nexa.
Right.
And
the ocular surface is done by the ocular surface department.
So really can't that,
Right, sir. Because that was in my mind because of the OSCE that we had shown.
Yeah. So what is the protocol at your center? Like, what do you follow there?
So for us we use ruthenium. So ruthenium we keep as a cutoff of 5 to 6 is the cutoff, beyond which we consider that the the area beyond that might not get covered. And yes, sir. And as per what we have discussed or read in that they say that iodine gets a little more advantage. That's why I was curious to know that they 2 to 3 mm of advantage. So what is the cutoff kept there? Because nowadays we have good salvage because of brachytherapy, and enucleation can be avoided. Right. And Ruju, do we have more questions from the hot seaters? Anything on the social portal? I have another question. So if that is not there, anything else is not there, I can ask another question. Sure. Right. So, sir, another question is that for capillary hemangioma, what is the time duration after which you would prefer to intervene with propranolol, like oral propranolol, because it slowly involutes? So what is the time frame that you would prefer after which you would like to intervene?
See, so rather than time at which I'd like to intervene, it is like how big is the tumor and what all functional compromise is it causing. So suppose it's localized to the orbit, to the eyelid, and it's causing a visual compromise and significant astigmatism, which can lead to amblyopia, and an orbital mass which is significant enough to cause optic nerve compression and visual compromise. So these are the indications when you would like to intervene and start the patient on oral propranolol, irrespective of the age of the patient.
Yeah, we have treated even as early as 2 to 3 month old children for large, because sometimes you only see the tip of the iceberg, you only see the eyelid lesion, but when you get an imaging done, you see that they have a huge orbital component also. So for such lesions, it's better to start treating.
But yeah, it's true that it is a little bit shaky in a small, like today only I saw a 1 month old kid with a eyelid capillary hemangioma, a lip hemangioma, and surrounding peripheral hemangioma. So in that kid, the parents told that the child is able to open the eyelids, fixates. So when I saw him in OPD, he was sleeping. So I told them, okay, you keep pictures and then you show me after 1 month. Keep a pictorial record at 1 week, and then we'll see like how is the eye opening, like how much stimulus deprivation is there, how much the visual axis is covered, and then we'll take a call whether to start the patient. Because the kid is too small, 1 month old kid.
It's important to check the refraction. These children tend to have astigmatic errors initially.
Yeah.
So it's important to have them evaluated by pediatric department also. The astigmatism simultaneously.
And Rolika, so rather than starting the patient on treatment, what confuses me is to when to stop the
When to
treatment.
stop the treatment, yeah.
Right, right.
That is
And-
the most confusing part, because I had a kid, orbital hemangioma. So patient was on propranolol for 6 to 8 months, almost nicely regressed. And when I stopped, they again started coming back.
Right, right. And you prefer just starting with oral propranolol and then observing how it's responding and maybe then going on to intralesional steroids. Is that true?
Yeah.
We don't give intralesional steroid.
No.
We don't.
Okay.
So if it is not responding to oral propranolol, then you need to consider your diagnosis. If it is not responding, then it most likely something else. Either it's a lymphangioma, lymphatic malformation, or a hemangiolymphangioma. So in those cases, you consider a biopsy, confirm the diagnosis. Because if it is a hemangioma in a kid, it should respond to propranolol.
Right. And ma'am, how many injections approximately do you land up giving on an average for like bleomycin per VLN, like lymphangioma case?
It varies. So children who have like really nice macrocystic lesions, well-defined cyst, you can aspirate the fluid. They do really well with sometimes just one injection. But children with larger lesions, which involve many quadrants, it varies from, we have given as much as 6 injections also, but usually they do well with 3 to 4 injections, but it varies. And sometimes they have multiple quadrants, so we tend to focus on one quadrant with each injection, because in children, the dosage that you give, you're limited by 0.25 to 0.5 milligram per kg body weight. So that limits the amount of dose that you can give in children, because sometimes they're just 10 kilos. So you're just going to give like 5 units, which is very little. So how much you're going to dilate? So you might require multiple injections in some children, but usually 3 to 4, they do really well. And the end point in lymphangiomas, you're not going to get rid of the lesion completely. It's just going to, it's a sclerosing agent. It's just going to fibrose the entire thing up. So you're not going to have a clear orbit.
A significant reduction.
Yeah, it's just going to be significant reduction. In fact, if you overtreat, they're going for enophthalmos with a superior sulcus deformity, and that becomes a cosmetic problem for the child. But it's important to warn them, because it's not gone completely. They can have a recurrence at some point later in life also.
Right, ma'am. Ruju, you had a question, right?
I have just, I would just like to add one topic, which is thyroid eye disease. I think that is another topic that people can ask, and especially the radiology. So you should know the tendon sparing, the Coca-Cola bottle sign, and the radiology. DDs.
How to differentiate thyroid from IOID.
And even I think I remember, like, I think
the lid signs.
The
favorite question of examiners is the eyelid signs. So please make sure you know at least 5 of them.
5 lid signs. You get like a Cocker sign or something. So
Mobius sign, von Graffiti sign. These are signs you should just have at your fingertips and just.
Correct. And I remember in one of my OSCEs, in some exam, I don't remember which one, there was an index on the CT index that was asked, which is the Barrett's index.
Barrett's index.
Yeah, that is thyroid optic neuropathy. So
they'll ask about the differential IOP, and in thyroid, these are things they'll ask: why lid retraction, causes of lid retraction. These are all-time favorite questions of examiners in thyroid.
Thyroid being the most common orbital disease, I think should like read up, and I think they would expect you to know everything about like the at least the science and the radiology part of it,
and also the classification systems which are used.
Yes.
So these are the UGO, then you have the no specs classification. So old timers will want you to know the no specs and expansion of no specs that they will want you to.
Kirthi ma'am, I had a question for you to add to the venous lymphatic malformation part of it. How often do we repeat those injections? What is the frequency of us repeating intralesional bleomycin? And
usually 1 month apart.
1 month apart.
Minimum 1 month apart for injections.
And ma'am, how often do we go in for a CT of the orbits, like after the 3rd dose or after the 4th dose?
No, we gently just repeat ultrasound. We do ultrasound guided. So ultrasound shows whether the cysts are reducing in size. So only when we see that there's a significant reduction in the proptosis and we think that maybe the child requires no further, then we repeat an imaging. So usually 3 to 4 injections later, not before that.
And the volume of this fluorescent which is being injected is subject to the amount of aspirate and what is the ratio?
Yeah, so usually if you're aspirating, you can give at least 25% with aspirate, 25 to 50%, but most often you'll get a dry tap. Unless you have a large macrocystic lesion where you're not going to get. So microcystic lesions, you're not going to have like, so you just depends on, you can give up to 2 to 3 ml for it.
Ruju, any questions? I think you were asking a question, no? I'm sorry I cut you off.
No. So one question I got from social media portal was, in which cases of BCC, topical management is preferred over surgical excision?
So if it's a superficial spreading tumor, so basal cell carcinoma, either you can have a raised nodal mass or you can have a superficial spreading tumor. So if it's a superficial spreading tumor, generally those tumors are quite large in area, and especially so if you do a wide local excision, there can be a large defect. So in those cases, you can try topical chemotherapy with imiquimod. Imiquimod, you can try topical chemotherapy. As far as I remember, it's day 1, 2, 3, 4, and then 2 weeks off, 2 days off. So that's how you give, I think, 6 cycles of imiquimod. So not for nodular lesion, for flat lesions. For flat lesions.
Yeah. And sometimes very large lesions, you can superficial ones on the forehead, cheek. You can use with the superficial ones. You can use they reduce the size and then you can excise them after that.
And these are very irritating. Once it goes into the eye, it causes a lot of inflammation. You have to be very careful that it doesn't go inside the eye.
Great. Thank you, sir, and thank you, ma'am, for covering the important OSCE. And I think somewhere down the line, more than the postgraduates, we enjoyed it. I think I'm taking a special joy in the ocular oncology sessions because we all are sitting like, glue on the screen and we're like, okay, yes, next question, we'll jump to answer. Thanks a lot for
something like not or anything which we did not know anything at all.
And when we don't know something, we go like, okay, we need to read this. So we are really happy learning from all of you. Thanks a lot for sparing out your time. And thank you, ma'am. I know you're traveling and still you made
No
out time
problem.
for us.
It's a pleasure to be part. Thanks a lot for giving us the opportunity to be part of this.
Right. Thank you, sir, for keeping everything together. And sorry if I troubled all of you last minute, but thanks a lot for everything.
Welcome.
Thank you so much. So our next session will be on 24th, that is Wednesday, and that will be the long and short cases by Dr. Sumit Lahane and Dr. Akshay Nair. So we'll see you on Wednesday with more interesting cases. It might be a repetition with a different perspective, but you'll enjoy. Like we do.
Thank our hot seaters, Ruhi, Vaibhavi, Varshini. If you can come online, that would be great. Thanks for being a part of this.
Yeah, you guys answered the questions which we were wondering to, like, what is the answer really did not strike. And they're like, we know it. So great.
Yeah.
Thank you, everyone. Thank you.